section scans can provide whole brain coverage. The other disadvantage of CTP is the radiation exposure. And as you've heard, the FDA released a notification whereby they found at one facility in the state, patients were exposed to excess radiation up to 8 times the expected dose of a CT perfusion brain scan. And 40% of these patients reported hair loss. High doses of radiation can cause cataracts and increased risk forms of some cancer. Hence, in this month's AGNR, Lev and Wintermark made some recommendations such that we should have dedicated stroke protocols that are tailored to certain settings as listed. And each CT protocol should be reviewed. A CT perfusion protocol, in their estimate, can be protocoled such that the radiation dose is equivalent to an extra CT scan. We're going to move to MRI and perfusion-related imaging. Again, MRI protocols can also be tailored so that you don't prolong your time for treatment. And it is thought that all these sequences could be accomplished within a time frame of 12 minutes. These are some suggested sequences to obtain on a stroke MRI protocol. Diffusion to look for infarct, T2 start to look for any areas of hemorrhage, and potentially could replace CT. According to Kidwell, is a big component of MRI, an acute hemorrhagic assessment for stroke. The T2 region and flare images are also helpful because ischemic infarction hyperintensities are seen at the earliest 3 to 6 hours after stroke onset. And they're no more sensitive for early infarct detection than CT. The flare is also helpful because it can detect subarachnoid hemorrhage very well through vein thrombosis. Dr. Davos nicely presented us to us yesterday about a series of MRI perfusion studies that have been performed lately. Several definitions have emerged from these studies. Basically, perfusion-rated lesions are defined as greater than 120% of the deep lesion. Malignant profiles have been defined, as well as early reperfusion definitions as well. In general, early reperfusion is associated with a favorable clinical response, meaning a dramatic decrease in the NIH scale by 8 points if there is presence of a mismatch. If there's no mismatch, there's no benefit from early reperfusion, given this from the diffuse study. And the malignant profile, which means if there's devaluation of 100 cc's or more, it's associated with fatal ICH with early reperfusion. So these patients should be avoided. However, there are some challenges to this idea of the core and penumbra theory. The deep calcified lesion that you see on your MRI is a heterogeneous signal. It's not always the same. From PET studies, there are regions of variable metabolic disruption and diffusion. And the other theory that's thought is that DWI is irreversible, but that might not be true. And these lesions can potentially be reversed with early recanalization. It's possible we can use ADC thresholds to separate reversible from irreversible DWI lesions. The Stanford group further challenged the idea of the core and penumbra theory, looking at type 1 geography versus type 2. Type 1 is defined by diffusion-rated imaging volume is overlapping the diffusion-rated imaging volume by more than 50%, whereas type 2 is less than 50% overlap. If the diffusion-rated lesion overlaps by more than 50%, we tend to have larger infarct volumes, whereas if it was less than 50%, there's a tendency for smaller infarct volumes and DWI reversal signal. This is an example from their study in Stanford, extracted from the diffuse study. This is the type 1 lesion with more than 50% of DWI within the DWI, showing larger infarcts. And then on the type 2 geography with less than 50% of the diffusion-rated imaging within the diffusion-rated imaging territory, there is a smaller infarct in general. I'm a big fan of the clinical diffusion-rated imaging mismatch, and we're very pleased that Dr. Davos is here. He initiated this idea in neurology in 2004. This concept is the idea of using the NIH stroke scale defined as 8 or more, and a small DWI lesion defined as 25 cc's or less. And he found that these patients were at higher risk for early neurologic deterioration. Other centers in Australia have found that this clinical diffusion mismatch can also predict the penumbra when they correlate this with MRI studies. This clinical diffusion mismatch is very specific for penumbra but has low sensitivity. So if you have it, you have a high chance that there is a penumbra. I'm going to move on to cases. This is an 80-year-old woman presenting with aphasia and right anesthesia, presenting at 3 hours onset, high NIH scale. No major changes on the CT scan. And this is the CT perfusion study, which Dr. Jandra, I'm going to ask you. So this is the, and here's the CDD, the core infarct. This is the territory at risk, which you're interviewing this patient. This patient's at 3 hours, 8 years old. You would. So I had an argument with my colleague. He said this is more than 1/3 empty territory. I said, yeah, but we can still try to save all these other areas. And so we just went for it. This is the angio, occlusion of the carotid, applied a suction, just a regular syringe suction, and out came this clot. And used a Mercy L5 pass with 1 pass, the vessel is completely recanalized. But you can see the staining on the parenchyma on the angiogram. And this is the result. The patient had a reperfusion hemorrhage despite a nice technical result. So we do make errors in judgment. This is a 75-year-old man who fell off his stool. I didn't tell you which side was his deficits because I wanted you to look at the CT scan and tell me if you see any early ischemic changes. Okay, so no obvious early ischemic changes. This is at 3 hours 25 from onset. I wasn't comfortable using that alone, so I went to diffusion-weighted imaging. There's a whole territory infarct. This is a flare, so based on this MRI, I decided not to go any further. This is a wake-up stroke, 82-year-old woman who woke up in the morning with a big NIH scale of 18, left-sided hemiplegia and eye gaze deviation. This is the CT. Basically, I was suspecting some early changes in the insula, and this is the CTA source images, perhaps some hypodensity here. And because she was a wake-up stroke, I wanted more information. And as soon as this diffusion-weighted imaging came up, I decided, no, that's all I need. I don't need any more information. I don't care what the diffusion-weighted imaging shows, which we did anyway, because we were trying to set up everything. Once I got the diffusion, I just run away, get everything set up, and go straight to angio. And then these images, regardless of what they show, I know I'm still comfortable with treating this patient. And this is after penumbra. This is the CT scan after intervention. Is this contrast or hemorrhage? Contrast. So yes, it's contrast, but there's also hemorrhage. I'll show you that on the susceptibility. So this is from the procedure, small area of hemorrhage, but overall this patient did fine. So in conclusion, depending on the availability, CT or MRI may be used. You want to tailor your protocol